come here together in this beautiful venue in Budapest, and my thanks goes to all colleagues who helped make this possible. My name is Franz Weidinger, and I'm the president of the European Society of Cardiology, and in the next few minutes I would like to give you some facts and figures to make the case for an EU and national cardiovascular health plans. Now, the ESC is a non-profit scientific society representing 57 national cardiac societies across Europe and the Mediterranean Basin and Central Asia. Our 100,000 members and decision makers are cardiovascular clinicians, scientists, nurses, and allied professionals, and patients from our patient forum are directly involved across ESC activities. The ESC is also one of 19 members of the European Alliance for Cardiovascular Health, known as EACH, which in turn represents every major organization in the EU dealing with cardiovascular health and the best interests of our patients. Several of our EACH partners will also be sharing their expertise here today. Collective data, knowledge, and expertise from across the front lines of cardiovascular disease have informed the paper you all received ahead of this meeting and the key messages that will be presented today. Across 4 different panels present today and together with you, we will discuss the biggest killer in the EU and the world, cardiovascular disease. CVD represents 37% of all deaths in the EU, which unfortunately is more than any other disease group. It causes 1.7 million deaths per year and more than 5 million new cases of CVD diagnosed annually. There are currently 53 million people in the EU living with cardiovascular disease. And yet, at EU level and for the majority of EU member states, there is no standalone policy plan, framework, and corresponding budget to tackle this problem. In addition to the terrible human costs, CVD comes with a heavy economic burden. Thanks to a study between the University of Oxford and the ESC last year, we know that CVD costs the EU 282 billion euros a year. That's 100 billion euros more than the entire EU budget together. When we consider the costs of cardiovascular disease, we tend to think of direct healthcare costs only, hospital beds, therapies, and the healthcare workforce. But this is actually less than half of the true costs of cardiovascular disease. 54% are societal costs, including informal care, representing almost 1/3 of the total cost, as well as losses from premature mortality and morbidity and social care. So when considering the price of action on cardiovascular disease, be aware that inaction itself is already coming at a terrible cost. It is often said that disease doesn't respect borders, but when it comes to cardiovascular disease, where you stand on a map can greatly determine your chance of having cardiovascular disease. Death rates from CVD can vary across the EU from 20 to as much as 65%. As you will know for your own countries, the incidence of cardiovascular disease will also vary greatly from region to region. Improvements have undoubtedly been made regarding treatment of cardiovascular disease, but we are less good when it comes to promoting cardiovascular health, with the situation often compounded when we factor in gender, geography, and generation, where major disparities persist. One of the greatest disparities in cardiovascular disease is undoubtedly one of gender. Of the 2.3 million female and 2.3 million male deaths across the EU per year, CVD accounts for 40% of female deaths than all cancer types combined. However, there is an incorrect public perception that women are at lower risk of cardiovascular disease. This gap is compounded by the underrepresentation of women in clinical research, a real problem for correctly and timely diagnosing and treating women with cardiovascular disease. And yet, there is not a single gender study that takes into account the greatest threat to the lives of women today. Now, primary prevention strategies are fundamental to reducing the burden of cardiovascular diseases. Studies show that many CVDs could be prevented by lowering blood pressure, cholesterol, and weight, by smoking cessation, and controlling diabetes. However, these risk factors remain highly prevalent in the general EU population. Whatever we are doing now is not working. We need bold and decisive policy and regulation with strong cross-sectoral collaboration. The EU has a legacy for such approaches. A genuine effort to fund evidence-based public health interventions in primary prevention can give youth a future and unshackle the concepts of old age and ill health across our nations. Pollution contributes significantly to the burden of cardiovascular diseases. To provide you with some context, air pollution remains almost as deadly as smoking in terms of the number of life years lost. You can see several data points on the slide that demonstrate the increased risk for CVDs and stroke from long-term exposure to particulate matter. And yet, air pollution in Europe is about 2.5 times higher than the World Health Organization recommendations. But we have a real opportunity. There was reassuring news from the World Heart Federation report in May this year, which showed that the number of people dying from CVD in Europe as a result of air pollution has fallen sharply as countries have cracked down on harmful emissions. The report highlighted that between 2010 and 2019, deaths from heart disease in Europe attributed to pollution fell by 19% and from stroke by 25%. Secondary prevention and early detection of disease are critical if we are to save lives and drastically improve quality of life. It is unacceptable that 60 to 80% of heart failure causes are diagnosed in the emergency department, that nearly half of all cardiovascular events occur in people with already established heart disease, that 25 to 30% of strokes are repeat events, and that 1 in 5 patients discharged from hospital after a heart attack has another heart attack, stroke, or dies of cardiovascular illness within the first year. Data shows that people with type 2 diabetes have a 2 to 3 times higher cardiovascular risk than people without diabetes and see their life expectancy reduced by 10 to 14 years. By identifying people with type 2 diabetes, we would be significantly better placed to prevent or manage their risk of cardiovascular disease. As a cardiologist, allow me to say that introducing a joint diabetes and cardiovascular disease health check could be one of the most impactful health strategies in individual countries and across Europe. It will be pivotal for the health of EU citizens across generations. Why are rehabilitation programs key? As said, 1 in 5 heart attack patients has a second heart attack, stroke, or dies of cardiovascular illness within the first year. How is this possible? Well, when patients are discharged from hospital care, there is often a lack of appropriate access to the rehabilitation services needed to regain a full and active life. The EuroAspire registry showed us that in the 6 months after a heart attack, 49% of patients were not put on a cardiac rehabilitation program. This could partially explain why more than 20% of patients were not prescribed heart protective medications, 58% did not meet blood pressure targets, and 71% did not achieve LDL cholesterol goals. Furthermore, as physicians, we are not in a position to offer suitable treatment options in end-stage heart diseases and care facilities for our patients with distressing symptoms at the end of life. The resources and infrastructure in many countries simply does not exist today. Rehabilitation policies that recognize the patient's needs after they have left the hospital would mitigate repeat events, ease the suffering of millions, and rapidly accelerate their return to the life they wish to lead. There is a huge opportunity for Europe to get back in the driving seat for innovative therapies that could be game-changing for the treatment of cardiovascular diseases. As you can see from this pie chart, only 4% of trials between 2017 and 2022 were for cardiovascular diseases. In 2021 and 22, no new cardiovascular therapies were approved. When we compare this to the burden of cardiovascular disease, it is totally inadequate. Currently, most cardiovascular treatments do not target the exact cause of the disease at the molecular level. With technological advances, more cost-specific and personalized management strategies are now becoming a reality in cardiovascular medicine. New drug targets may be identified using advanced technology such as genomics and proteomics. Precision medicine has the potential to bring considerable long-term gains and has already proved successful in other disease areas such as cancer. High-quality data and real-world evidence are essential to improving treatment and driving care innovation. Indeed, improvements can only be made if the epidemiology of cardiovascular diseases in Europe and treatment patterns are accurately understood and built on strong evidence. And yet, only 25% of national cardiovascular disease registries in the EU are supported with public funding. Relying on the private sector funding and donations is an inadequate model to maintain reliable and robust data. Investing in a European data center that reflects European citizens and European healthcare delivery is not just necessary, it is fundamental to progress in cardiovascular disease. Every minute, 3 people die from cardiovascular disease, meaning that in the 24 hours we will have convened together here in Budapest, 4,600 EU citizens will have died from cardiovascular disease. I've provided you with a lot of statistics here today, but behind each of these numbers are unique individuals with their own lives, their own friends and families, their own battle with cardiovascular disease. On behalf of every cardiovascular scientist, physician, nurse, and allied professional that I represent through the European Society of Cardiology today, I urge you to keep in mind each person affected by cardiovascular disease as we discuss how we can tackle the EU's biggest killer. Together, we must and can do better. Together, we can save lives. Thank you very much.